Okay. You're live, Sujata.
Okay. Should we start?
Yes.
So good evening, everybody, and good morning, Dr. Palermo. On behalf of ACE, I have great pride in welcoming you all to this new feature, which is the conversation with pathbreakers in the field of IVF. Since this is our first episode, I would just like to give a little bit of introduction on this event. So what is that exactly we are aiming to achieve by having conversations with pioneers?
You're live,
As
Sujata.
you all know, that a good conversation is a good stimulant. And it can actually help us to motivate or have meaningful connections. And it will also enhance our vision in the field of embryology or in the field of reproductive biology. See, about techniques like ICSI, how do we do it? For whom do we do it? How do we get best results? We can always go through publications, we can go through textbooks, and we can understand and we can learn. But what actually went behind that journey? This is something which actually all of us should know, because, lot of things which the person who has done that will not be published anywhere. So it would be really interesting. It would be really be stimulating. And then many a times people, they just say that embryology is, or embryologists are just glorified technicians. But these are certain things. These conversations would help us to elevate us from the status of technicians to scientists. So that is the intention of having such conversation with the pioneers or the pathbreakers in the field of embryology. With this, I once again welcome you all to this evening, where Dr. Rajvi is going to talk to the father of ICSI, Dr. Jean Palermo from Cornell. And I request our Secretary ACE to give an introduction about the VIP today.
Well, I will say thank you, Dr. Suyata Ramakrishnan, and I want to thank you, Dr. Raji Mehta, and Dr. Gurav Mayodar for the kind invitation. It is a pleasure to be with you, and I'll try to be of any help I can to try to kind of elucidate or kind of enlighten your future career. So yes, maybe you want to start with the first question or any comment you may have.
I think Gaurav would like to first give a little introduction.
Yes,
So over to you, Gaurav.
So good evening, Dr. Palermo, Dr. Rajvi, and Dr.
Good
Sujata.
evening.
I would give a quick introduction to both our the interviewer and the interviewee. We have our very own Dr. Rajvi Mehta. She is a PhD in human IVF from ICMR, and she's in fact one of the first doctorates in human IVF from India. And she has a vast experience of 3 decades in human IVF as a researcher, as a clinical embryologist, and as a teacher. Currently, she holds the post of Joint Treasurer of the Academy of Clinical Embryologists of India. She's also the convener of a special interest group on holistic medicine for Indian Fertility Society. Has been invited speaker to many conferences, including ESHRI and IFFS. She's also acting as a consultant on the board of Cooper Surgicals India and Trivector Biomed. She's also authored the Imagine If series, which are stories of ordinary people with extraordinary grit. So I welcome you, Dr. Rajvi, and look forward to this enchanting evening with you interviewing Dr. Palermo. Now, let me introduce Dr. G.D. Palermo to everyone here. He is a professor of embryology in obstetrics and gynecology and the family professor of reproductive medicine at the Ronald O. Perelman and Claudia Cohen Center for Reproductive Medicine of Weill Cornell Medical College. He received his medical degree from the University of Bari in Italy and received his PhD in reproduction and development from Monash University in Australia. He completed his residency in OBS and Gynae and his fellowship in reproductive endocrinology and infertility at the New York Presbyterian Weill Cornell Medical Center. He is a board-certified obstetrician and gynecologist, also in reproductive endocrinology and infertility from the American Board of Obstetrics and Gynecology. He is a member of both the American Society of Reproductive Medicine as well as the ESHRE. Furthermore, he has been the director of assisted fertilization and andrology at the Ronald O. Perelman and Claudia Cohen Center for Reproductive Medicine since 1993. Dr. Palermo was the first to describe intracytoplasmic sperm injection, a solution to complete and unexpected fertilization failure with IVF and male factor infertility in 1992. Since then, it has become the most utilized assisted reproductive technology in the world. Dr. Palermo lectures both internationally and has authored and co-authored over 150 peer-reviewed manuscripts, over 30 book chapters, multiple textbooks, and over 440 abstracts presented at congresses across the world. He also serves as a reviewer for multiple high-impact journals, including The Lancet, Nature, Fertility and Sterility, Reproductive Biomedicine Online, and the Journal of Assisted Reproduction and Genetics, where he has also served as an editor. Dr. Palermo specializes in the assessment and treatment of the infertile man, including sophisticated, non-traditional sperm preparation techniques and the correction of fertilization failure. It is my privilege and honor to be inviting you, Dr. Palermo, to this evening, and we are excitedly waiting for this new feature of ACE. Please welcome.
Thank you, Dr. Gurav. Thank you for a wonderful introduction. I appreciate it.
So good evening, or rather good morning, Dr. Palermo.
Morning.
And I really, really appreciate you coming, and I'm sure all the people who have joined in. So generally, we talk about infertility, we talk of clinicians and embryologists, and here we have an individual who is a clinician and embryologist. So often in our community, we always talk about, the clinicians and embryologists, and they are two separate parties, and we try to bring them together on the same table. But here you have somebody who, as I understand, is a clinician and an embryologist. So can you give us a little brief of how you got interested in this field? How did you get into science? I mean,
Yeah,
so,
sure.
yeah.
Thank you, Dr. Mir. So all started in Italy. I graduated medical school, and then I wanted the most difficult specialty, and I chose OBGYN. So once I got in OBGYN, I finished that, and I realized that was not really my interest in delivering babies. So I had a mentor, a professor there in Italy, and he had a big private clinic, and he was starting in vitro fertilization. So I thought it was new, fascinating, and I started to follow him. And he said, we need somebody that goes abroad and we learn good level in vitro fertilization. So he proposed me to Brussels, to the Brussels Free University. At the time was a new, very popular center, one of the largest in Europe. I mean, when I left, it was a 5,000 cycle per year. So that's my history. I did a sabbatical there. It was supposed to be 4 months, sponsored by the University of Bari. Then instead of 4 months, it became 1 year. And during that year, they told me that the major problem in the field was male infertility. I said, but I'm a gynecologist. I'm not going to work with sperm, I thought. But fortunately for me, I listened and I started to look into it. And that's brought, in brief, to the development of ICSI.
Generally, as my understanding is, a clinician has wide thinking. because you have to diagnose an individual's patient. So you cannot have a narrow mind. You need to have broad vision to identify, while a researcher is a vertical thinking. So clinician has horizontal views. A researcher has to get narrow and deeper and deeper and deeper to find solutions. So how do you mix the two together? Have
Well,
a horizontal thinking pattern and a vertical thinking pattern.
well said. Yes, as a clinician, you have to be open-minded. You have to look at, you scan the horizon to have an idea where are you going. As a scientist, you just take your task and you go very narrow view, very, very deep. You said wonderfully. And yes, my mind is adaptable. I have the tendency as a personality to be obsessive compulsive, and I have the tendency to get distracted from the big picture. So in one sense, reproductive endocrinology, if you think about, we are very, very narrow into infertility treatment. So it's not so broad. It's not a general practitioner or an emergency room physician. So the patient come in, they want a baby, so you start to think about 2 or 3 things. Male factor, actually, I'm one of the few clinicians that think about the male. Most of the reproductive endocrinology are focused about the female. They just ask for a semen analysis sometime, not all the time, and they focus on the female factor. Well, so I try to combine the two. You see, I believe if you love something, you'll be able to succeed. So if you are passionate, you focus on something, then you'll be able to identify. When you see the patient in front of you, whether it's for the embryology aspect or for the clinical aspect, you just have to see what they need. And the beautiful things with reproductive medicine, the patient is healthy, knowledgeable, as you know, very demanding.
Okay.
And even as an embryologist, you can have that sense. I mean, for those of you who are exposed to the patient need, I mean, certain centers are open and let the embryologist speak with the patient, so you get an idea about this. But it's all about focusing on the problem, the ability of focusing on the issue.
So that's what you said very interestingly, that what do you do in the male? Only semen analysis. And I always keep commenting that we are very biased. So in India, we talk a lot about gender discrimination and, socially. But I feel in infertility, gender discrimination is against the male. So society still perceives infertility as a female problem. Whom do the couple go to? They go to a gynecologist. Again, you go to the female. The gynecologist has a whole series of battery of tests which are reasonable. I mean, you're going to do a hysteroscopy, you're going to do an ultrasound, you're going to do an endocrine profile, you're going to do follicular monitoring. When it comes to the male, it's a semen analysis. So again, clinically, we are biased against the male. When it comes to treatment, there is so little that is offered to the male. And when it comes to research, it's still more little. So why do you think, I mean, and even if we talk the number of gynecologists versus treating infertility versus number of andrologists, it's so skewed. Is this the same across the world from your experience? We see this in India.
Yes, I was trained in Italy, and I know that the OBGYN take the role of the reproductive endocrinology in the United States, which is a 3-year subspecialty. But yes, in most of the countries, the gynecologists take care. And it's a matter of training. They are just not trained for the male. That's so, and they didn't develop an interest. I was kind of guided to look at that. So I was told the male is 50% of the equation. Yes. So, it participated much as the female. And the point is, the semen analysis tell you numbers,
yes,
not really function of the gamete. And that's what the problem is. And sometimes, I know as an embryologist, you have the issue in the lab, and it's hard to explain to the clinician. They say, oh, but the sperm is normal. Yeah, but it didn't work. And so you got to explain, and they think that something was done wrong in the lab. They didn't bring the result that they were expecting in spite of the number of sperm. And that's the most shocking thing. You have a normal semen analysis, apparently normal, and still the gamete doesn't work.
Yes. So I think you hit the nail, because a lot of embryologists, and like I said, in India, we have generally a clinician or embryologist, very rare cases combined. And there's generally a feeling, we gave you oocytes, we gave the sperms. and we didn't get good embryos. So who's to blame? So the
Right.
embryologist will say, okay, what if the raw material is not good? What can we do? So I think you hit the nail. Don't you, where do you think in the world this scenario is changing? I mean, you've traveled
I
across
hope
and you meet people, it is changing, but where do you think that there's equal weightage given to both? Do you think, is it there anywhere in the world?
I think it's changing. I think, I know this with my colleagues. You see, before starting to see patients, because I was focused on research, clinical research, and the clinical laboratory. So, but I got question, and even now that I have my own patient, the colleague asked, oh, the patient got a poor fertilization, what should we look at? So I developed a certain number of tests to look at the function of the sperm. And also, there is a tendency too frequently to blame on the technology, on the technician actually, the poor result. And that's the reason why there is a kind of a change of heart in going back into IVF, because they blame the technician because ICSI didn't work so well.
Mm-hmm.
And the issue is, I know this with the stimulation, for example. Since we have introduced the antagonist, I noticed that, you see, when GnRH analog was introduced, there was a discrepancy between the maturity of the cumulus cell and the maturity of the nucleus. When we introduced the antagonist, I know that there is a discrepancy, a dysynchronism between the nuclear maturity of the egg, so the extrusion of the polar body, but with the maturity of the cytoplasm. So the cytoplasm is still at M1 stage while it has extruded the polar body. It needs more time to receive the sperm to act upon. So if you do too early, ICSI is going to fail, particularly in certain patients. That's my take on it. So what I do, I adjust the timing between the time of ECG and the retrieval, so to have enough in vivo maturation of the eggs. And I have a paper, I think 2006, on RBM Online on that. And so that's the reason started because we have patient. Maybe I hope I'm not digressing from the question,
No,
but I give
please.
you this example. So you have patient that the normal semen parameters, younger women, then suddenly you get no fertilization. They have one cycle with fertilization and then one cycle with no fertilization. And that's where I got the idea. I got like 16 patients that way, and I started to look at the time. And I saw when there was no fertilization, the issue was that there was less than 35 hours between the HCG and the egg retrieval. And then allowed at least 2 hours between the retrieval and the removal of the cumulus, paramount. Then really the time between the cumulus removal and ICSI, about 1 hour, 1.5 hours, is not that stringent. But the in vivo maturation is paramount.
But there has been a tendency with the antagonist protocol to do a pickup before 36 hours. And especially in the earlier days of antagonist, when people didn't get the timing right, they would pick up early. Now, the question is, in these cases, if that has happened, at least we should not denude. At least the cumulus keep it together.
I mean, yes, at least not the nude. Leave the cumulus cell. Although at the time of ECG, the projection, the corona cells are withdrawn from the egg, as you know,
yes,
but still it has an important role. And this you can learn from the in vitro maturation experiment, that at least 1 hour before remove the cumulus cell, you have to, after the maturation, the extrusion of the polar body. So you won't allow the cumulus cell to sit there with the eggs.
So we'll go back to the early days of ICSI. And the story goes, I mean, that's what I have heard or maybe read somewhere, that you were working with artificial assisted fertilization, introduction of the zona sperm into the perivitelline space, and you happened to get into the ooplasm. So is this story true? I mean, it was incidental.
Yeah, no, I mean, the story is partially true, but there was some background thinking there.
Okay.
When I was asked to do this work, I started to mess around. I wanted to start my experiment. So I started to take unfertilized human oocyte to inject, just to get the feeling, to perfect the needle, the machine, because, I came up with the tools myself. So I have to make the tools. They were not available. They were not in the market. So that was the most difficult thing. And that was actually allowed me to succeed with ICSI, because the previous tools were very rough, while instead I'm a perfectionist. I'm very prone to mechanics. I can fix about anything with my hands. So I made the tools that I think were right. So the tools were reduce the damage to the egg as much as possible. So I did that. Then I want something more alive. Then I started to do hamster eggs with human sperm, just to get the feeling again. And then I was told that in order to prove my point, I had to inject, a biological living gamete. So I use mouse eggs and mouse sperm. I hate it because the mouse sperm has the perforatorium, and the mouse egg is very sensitive, as you know. It's impossible to inject normally. You need a piezo device. So I tried the ICSI with a mouse, didn't work. They would degenerate. So I did one single sperm in the perivitine space. That's when I got PAPS. I was allowed from my boss in Belgium at the time, André van Stertingen, to move to the human. But because Simon Fisher at the time was popular in Rome, he was doing subzonal injection, I was allowed to do subzonal injection only. I told not to do intracytoplasmic injection because it failed with Eng in Singapore, Satananta study. They say there was Lucinda Vick, did 16 patient and never got the pregnancy. ICSI doesn't work, so don't do it. Don't even think about it. But I like the idea of having one sperm, one egg. I thought I empower the sperm so much that I can bring it to 1-to-1 ratio, but it was not allowed. So when I did the subzonal was done at 6 o'clock or 12 o'clock, and you put about 12 to 20 sperm in the perivitine space. Well, I thought too many. It looked like a subzonal insemination, it's like IVF into the subzonal space. So I'm going to reduce the number of sperm, and I went down to 3. And I said, I'm going to do at 3 o'clock instead of 6 or 12 o'clock. So I created a little invagination of the membrane to facilitate the intermingling of the two gametes. And then I was inducing also the agrosome reaction on the sperm, because again, I thought about the sperm and not just a mechanical thing. So, but by doing that, the pipette was sharp and one sperm swam inside the egg. So, and this was occurring there and there. I thought the egg would degenerate, right? But in one patient, it's happened, and I put a question mark next to the egg. And then when I look at the following day, nothing fertilized except that egg. So, but we didn't pay attention to it, and we move on. And this was happening. So I told to my technician, maybe to leave a track in the history of medicine, we should have a pregnancy with intracytoplasmic sperm injection. And Hubert Joris, my technician, said, we have it. I said, what do you mean? What are you talking about? So we went to look at this patient with the 12 eggs, and the only one fertilized. And that one actually was an embryo. At 2 days was fourth cell, was transferred, and gave the first baby, the first ICSI baby.
Okay.
So it's serendipity, but I wanted to make it work with a single sperm. So it was in the back of my mind, in my heart.
Okay. So yeah, serendipity, although one may say there is a lot of background work that goes to make it appears as serendipity. It appears to an outsider. It's not just luck. But
see, Pasteur used to say the major discovery happened by chance, but you need an educated mind to recognize it.
Absolutely. Now, see, it is invasive, no doubt about it. And now going back in time, you were not aware that this embryo was transferred, possibly, till your technician said there was a pregnancy.
Well, we used to choose the embryo, send it back. For us, it was subzonal injection. I put just a question mark. I didn't think much about it.
Yeah, you didn't realize the impact you're creating in the world.
Yeah. When I realized, then, I start to do it again. So what I was doing is do a set of subzonal. The last 3 eggs, I would inject into the cytoplasm, and I had to figure out a way to spare the life of the eggs. So I thought if I break the membrane just a little bit, and then I put a sperm there and I get out, the egg will survive. Instead, the egg would die. So I had to figure out, I have to go deep all the way to 9 o'clock to allow the olemma to seal and the egg to survive.
Okay.
So when I was getting those embryo, then I would start to send those embryo back to the embryology lab, and then I got the second pregnancy. Then I told my boss that I succeed, but he didn't believe me. He said, sure, whatever. Young investigator enthusiasm, he said. And then I did another pregnancy. I got 3 pregnancies. And I told him, I said, oh, that's Italian excitement, he said. Then the 4th time, he said, now we will publish.
Okay. But, I mean, you kept injecting and you got the embryos. Initially, the first time the technician later told you that it had been transferred because it was just a question mark. Only that
Sure,
one developed.
It's not that, yeah, we didn't think much of it.
Yeah.
It's only when this happened more frequently, because the method, the tools, the technique was excellent. So when the accident was happening, you would get fertilization of embryo. So the system was well designed since the beginning, because I designed it with perfection in the mouse, and I use the same system in the human. I never change anything.
So,
I'm so dedicated to detail.
okay.
That's allowed. In fact, ICSI, the way I do it, had never been changed since the beginning. It was, you see, I tried to develop a shark. The shark stopped evolving millions of years ago because it reached hydrodynamic perfection. And that's what I thought. I want to design ICSI the same way.
Okay.
And no one has been able to change it.
So one day we would love to see a video of you actually doing it. A perfectionist.
It's the same. It's the same. The difference is I do not aspirate the membrane like Brussels taught the rest of the world.
Okay. So, no, because
I feel the membrane and I know how to stretch it to break it.
Okay.
And I use pipette a little bit wider than the other, than my collaborator.
Okay. So gradually the tips are coming in of small things, because it's these small things which are going to make a big difference. Everybody does the same things. It works in some hands. So one day we're going to get back to you and say, hey, we want to see a video of you doing it. And
I will tell you this, many people are struggling. And the reason why there is a fashion to go back to IVF, the new media company, they are making it impossible to succeed with ICSI.
Okay.
Because you have more damage rate, more 3PN rate. And then they blame the technician. All you have to blame is the medium that they're giving to you. This medium for time lapse, this I don't want to say the name, this media that you don't have to change throughout. What are they doing really? The secret is they remove glucose and they remove proteins. By removing protein, they make your life impossible. So I have to make my own injection medium.
Oh, that's interesting. So you add extra protein to your injection medium?
Yes. And I adjusted according to the medium. You see, we have a very unique laboratory. We have 3 directors in the lab, no 1 director. So there is 1 director that takes care of the embryology lab. And the embryology lab, they do egg freezing. They clean the eggs for me, for ICSI. And then they do embryo freezing, egg freezing, and they do everything on the time lapse. So then I'm the director of assisted fertilization. So I take care of, I'm the director of the andrology lab, that is a different separate lab that take care of patients, and I have also New York State certification for that. And then I take care of all the ICSI team, where we go there, we inject. I take care of the machine, also for the PGD lab. And we do also the testicular, the search, the treatment of the sperm, etc. Then there is a director of the PGD, but the PGD lab, they don't just do biopsy, they also do genetic. They do the sequencing themselves. So that's the reason why we are 3 different people that join into one place to take care of our patient. Okay, so that's allowed us to have a different perspective, let's put it that way, and more talent in one sense. Through 3 different teams that they go to visit the same place to take care of our patient, not just 1 director to take care of everything.
That's very interesting.
Yes, that's how it is at
yeah.
Cornell. That's how it
Okay.
is at Cornell. And so I do a lot of research on the male factor. My team of andrologists, they mostly are just people that finish college. They know nothing about the laboratory. I train all of them myself. Some of them that are most talented, I became, ICSI operator, and all of them present at the ESHRI at SRM every year. So all of them, they are into research. We collect data for ICSI, and we publish as much as we can. We are the most published group in the entire center. So that's very unique, but it takes a lot of coaching.
Yes.
I
So
also take care of the maintenance of all the machine also for PGD, because need to make sure that they have the machine in a perfect condition. And I like to compare the machine my manipulator are designed for me. The heating stage are designed by me. So I look at all the different aspects of it.
So you don't use the ready-made from the standard companies? Your equipment?
I use the Narishige, but the Narishige, the father of Yuki, and the Yuki now is the the owner of the company, and they make the machine according to my design, the way I want it. And I mount the machine the way I like it. I
But
compare my machine to a Ferrari. So very simple, but very effective, very fast, and very safe for the end.
okay.
That's
So do they also, since you the amount of experience and and also a workman who likes tools, who designs his tools,
I
do
love
the
tools.
companies?
I should have been a mechanic.
Okay. So
When in Belgium I saw the first manipulator, I saw all that screw. I said, if I can get into this line of work, I don't have to work any one day of my life. I'd be playing every day. And that's what I do.
okay. So you're not working, you're playing
No,
every
I'm
day.
not working. I'm
Okay,
so
wonderful.
fortunate because you ask how long you've been at Cornell. I play every day. They let me play. I'm being fortunate because André Van Stertingen and Zev Rosenwax, the two boss that I had in the field, they let me do what I like. They let me free. And especially they trust me in training my own team. And I'm very grateful for that. So they don't interfere. And I have the utmost commitment in providing the best result I can ever imagine because they let me free to do what I like.
Okay. I'll go back in time again. Once you knew that the ICSI, accidental ICSI embryo was transferred and the lady was pregnant, did you ever have any apprehensions or fear of final outcome? Whatever said and done, here was a technique. I mean, even when we try drugs, we try it on animal models, you go to larger models and you have clinical trials. Here we had jumped directly into humans. And whatever said and done, everything seems fine, but it is invasive. A little bit of oil has gone in, PVP has gone in, and the final
No, there
outcome.
is one most important thing.
Okay.
It's going in sperm. They're not
Uh,
supposed to get a baby. That's the most dangerous thing, not the technique.
okay.
These are sperm, individual sperm that these men had and were labeled as azoospermic. So nature didn't allow, or some people call it God, did not allow these people to reproduce. And I allowed this sperm that's not supposed to create an offspring, I allow this sperm to conceive. That's the most dangerous thing. The tools, the pipette, the things, the risk is nothing in comparison. That's what the concern is. To use a genome that's not supposed to generate an embryo. That was and I'm a clinician first. So
Yes.
I was terrified,
Yes.
excited, but extremely terrified. But again, I had a good mentor. With Andre, we talk about this. And we have to do prenatal diagnosis, follow up the pregnancy, follow up the children, inform the couple of the risk.
But how were those 8, 9 months, or especially before the prenatal diet?
We were doing more cases, but explain the patient the risk that they were doing this technique. We didn't just decide to do this technique. Once these people, they knew they didn't get fertilization before. In fact, I was asked to do sibling eggs, to do half and half, like Jacques Cohen did here with the PZD. Simon Fisher was doing with the subzonal. I told Van Stertingen I refuse to do sibling eggs, because then we're going to do with the embryo. We're going to mix the embryo, and then we don't know what is what. How do we know it's safe if we mix the embryo? Then we pretend it's safe, but it's not safe. So I said, just do IVF 1 time, 2 times, 3 times, 4 times. If you don't know what to do, then you send it to me. That's what I told them. I got a lot of heat for that because they thought I was crazy. That's not reasonable. But I don't want to mix. So they try at least people with 2 times complete failure of fertilization. Then they gave it to me.
Okay.
And also you have to say, we were doing subzonal injection before ICSI. Subzonal injection, we were terrified as well to create abnormal children. So Brussels was the first center in the world to follow up the children born from assisted reproductive technology. Nobody ever cared about it before. But we worry about that. Already with the subzonal injection, we did, even with standard IVF. And then we start to look more and more and more, it's particularly with ICSI. And the best study came from Brussels. And then Belgium was followed by Göteborg and New York as well. And I did it here once I came to New York.
So, like you rightly said, let's not bother about the technique, but the sperm. And when nature or God had not made it possible to have it, possibly because of compromised health of the sperm. Now, in that case, was there a concern? I mean, because that the baby would be healthy? Because to me, it is a lot of pressure to wait to see the outcome. It's an experiment is fine. But when it comes to, experiment to a child being born, and what if, did that ever bother you? Because it's a lot of stress. And being a clinician
it's a lot
also.
of stress, but that's the reason why you have to look at detail. How you make the tool, how you sterilize them, the media, the dishes, the timing outside the incubator, the heating. For me, the most important was to keep the right temperature. All of these, because I knew I was trying to create embryo that were going to be transferred to patient. So even before start, that's, I think, the benefit of being a gynecologist. I was trained to deliver baby, to protect life. So that's what I had in my mind. So to be very, very cautious with what I was doing was not just the excitement of the moment. So that concern was with me all the time. Even now, I always worry about the children. And that's the reason why I wanted to know more about the parents. Thanks God now we can do the expanded carrier screening, so we know the inherited disease. Because I got ICSI parent and so, the baby has that condition. And then they find out in the family, they have a relative with that condition. But immediately you blame it on ICSI. But they didn't know that the relative had the same disease. Now with expanded carrier screening, we are aware of it. I always want a karyotype. I always want the expanded carrier screening. I always want to know as much as possible about the parent before doing that. Not because I'm going to tell them yes or no, but because I tell you should be aware of what the risks are before doing anything.
I get your point that it is not the technique. I mean, in novice hands, yes, it's a technique, but in skilled hand, it's not the technique. But still, today, I do believe that we still don't know how the zona selects the sperm. And even the best embryologist in the world, we've had IMSI, we had PIXI, we have a lot of things coming and going, which may contribute to some extent. Do you
The
think,
point is this.
especially
You're saying that
selecting a
zona,
good
right?
sperm from the bad sperms?
The zona select the sperm. This sperm that is as a small acrosome or no acrosome, or is testicular or epididymal, is not supposed to go through the zona.
Correct.
That's something should be clarified in our own mind and the patient mind. It's not supposed to go through the zona. So or you do it or you don't do it. It's not supposed to try to simulate because they are not, like, I had a patient, did IVF, ICSI, in a very well-known place in the Midwest in the US, never fertilization. Is a completely globospermic individual. We have to search long time to find spermatozoa. They look less round-headed. I got 2 fertilized and they have a baby. So these people, they knew they had no chance to have a baby whatsoever. Even with ICSI, it wasn't possible. With OSA activation, we were able to get 2 fertilized. So, but the patient understand. I mean, I've been accused, to play God. But the point is, you wanted to help these people. I tell the patient, you have to help me so I can help you. We have to be together on this. There are certain things I know, certain things I don't know. Are you with me or not? That's what it is. That you have to clarify with the couple.
My concern is that when we have male factor and there is severe teratozoospermia, and you have a lot of abnormal sperms, and while you are doing an ICSI, and I'm talking not of the Dr. Palermo, who is very precise, detailed, but an average, because the technique is all across the world, and you're trying to pick up the sperm from all the not so good sperms. So somewhere are we, what are the tips in that case? Somewhere are we contributing in not getting the right selection?
I mean, the phenotype, fortunately, the phenotype is not a genotype. So
Yes.
we inject sometime, if there is nothing else, we inject very, 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 very ugly sperm. As long as there is one head that look more or less, the size, even if you have some testicular case, they have a very bad sperm. And but you inject anyway, again, explain to the urologist, because the urologist retrieves those sperm. Explain to the urologist, explain to the patient, but then you try with those sperm. And we got babies, healthy babies. So fortunately, it's nothing to do. But I had another couple that had IVF, testicular sperm, somewhere else, very poor sperm, but he had a translocation. We know it was genetically abnormal. This sperm would not work. We did, after 6 IVF, 3 in one place and 3 with us, we were able to get normal embryo. But I insisted the couple, they wanted to do transfer, fresh transfer. I said, we have to do PGTA. I need to know that they are normal before transferring. The woman will say, oh, but even if he's an abnormal child, I would love it anyway. I say, it doesn't sit well with me. So, we did PGTA, we got a normal embryo, we transfer, they get a baby. So, but that's, they're already abnormal.
So what are the tests that you
So the
would...
zona would not help.
Okay. So what are the tests you would say you would do on the male? Like semen analysis is very, very superficial. You just know the count, motility, and morphology also. But then when you're actually picking up the sperm,
Morphology
that
is
has
very
no matter.
superficial. The morphology
Very
will tell you
superficial.
the acrosome is small and there is a small acrosome.
So it is not
It
meaningful.
doesn't help. So I want to know if the sperm is going to, has a chance, ability to fertilize. Then I do a PLC zeta assay.
Okay. So what are the tests would you do on the male before going for ICSI?
It depends. If it's a problem with fertilization, then I do a PLC zeta assay. If the PLC zeta is adequate, it's just a matter of finding the sperm with the largest acrosome.
Largest acrosome.
PLC zeta is low or absent, then I will work on OSA activation.
Okay.
Then if the patient has abnormal embryo, for example, and the wife is young, so then I think it's more a contribution on the sperm. We do FISH on the sperm, we do DNA sequencing on the sperm, and we do centrosome assay on the sperm to assess if the centrosome is present on those spermatozoa. Because the centrosome I published in 1994 is what ordained the first mitotic spindle, ordained the segregation of the chromosome. So that's some of the tests we do. And then if we do DNA fragmentation, and then we do microfluidic selection, we do sex selection on the sperm. These are all the tests that we do.
Okay. which is, in case you're not aware, sex collection is a criminal offense in India. So we are not allowed. Yeah.
In
But
Europe also, it's not. In the UK, it's not. I don't know. Oh, it's a criminal offense even if you do it on the sperm?
yes.
No, okay.
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 Yeah.
I mean,
So,
I'm not here to project my feeling or whatever the
no, that's
is
fine. I mean,
what the patient desire, I will go with it.
yeah. So the thing is that, when we are trying to select, and you mentioned a lot of techniques and things that you do, but the question comes, when we are actually doing the ICSI, all these tests would not be meaningful because when you're picking up the sperm, you don't know, whether it has fragmented DNA or not. Because you do a DNA fragmentation, they say, so many percentage is having DNA fragmentation. But when you're
But
actually picking up,
if I have DNA fragmentation, you know already what according to my study on prospective on chromatin fragmentation, I don't know where it was published, 2018, I think, or 2000, no, much later. Yeah, when 2000, I don't remember. 2018, I believe. 2016 on fertility and sterility.
okay.
So there I demonstrate that there was a direct positive correlation between the chromatin fragmentation and the sperm motility. So with ICSI already, you suffer less from the chromatin fragmentation, from the chromatin fragmentation of the sperm by selecting the most motile. So with ICSI, as long as motile, you have a lower chance to get genomically compromised spermatozoa. But if you do microfluidic, you bring the DNA fragmentation down to less than 5% in most of the case. So that's how you improve it.
Okay. So to summarize what you're saying and to get it clearer, because if we do a DNA fragmentation assay, we just know the percentage. And if it is a high percentage, the probability of picking up a fragmented sperm is higher. The probability, but if you go for a highly motile sperm, your chances of picking up a fragmented sperm would be lower. If you go for a sperm with the largest acrosome, the chances are that it will have enough PLC zeta to activate the oocyte. And what you're saying. Now, you also mentioned about fish, but what do you, and microfluidics, that's the third thing you said, that you get the very small percentage of sperms with DNA fragmentation, and that is the reason you will get
Also,
chances.
when we do microfluidic, you have also lower chromosomal abnormality.
Okay. So these are tools to separate sperms by which you would get select the sperms. So you're talking of largest acrosome, you're talking of highly motile sperms. Now, when do you do, the question has come up at how do you choose for a large acrosome? It's a subjective thing. Just your
Well,
experience tells you.
that's anything you do is a matter of learning. That's the reason why I told you I have the andrology lab. So my ICSI operator, they work in the andrology lab as well. So they work with sperm all the time. That's a different. They are not embryologists. They don't really work with eggs, other than at the time of injection. They never look at eggs or embryo. They just work with sperm all the time. All the time. So they get the feeling on the sperm that they look in the andrology lab, the sperm they look into the PVP, a slow motion.
Okay, so that's how they
So they develop
subjectively.
an expertise to recognize the microsome and the way it moves the sperm, the neck, how it appears, if it's bent at all, over a certain amount. So you don't take because if it's a bent neck, you worry about the centrosome.
Okay.
So you have to look at all the aspects of the sperm. You see, we are beyond the semen analysis. Semen analysis for us is almost useless.
Yes. So you're looking at many more factors in a live sample.
Correct.
Basically.
Under
Not
light microscopy. That's where you have
okay.
to develop a skill. In fact, we train also to look at immature gem cell into the testicular biopsy, fresh. It's very hard to do, but according to the size of the cell and the nucleus cytoplasmic ratio, you can identify if there are immature gem cell like spermatid, and that will tell you what type of testicular sample you have. Not that we inject those, but this, what type of sample you're dealing with. So if you found some dysmorphic sperm, you can use it because there is some sort of progression into the spermatogenesis. Also, we do spermoneogametogenesis. We do experiment of neogametogenesis in our lab. So the same technician. So we try to go from the stem cell of the neonatal testicular sperm that we got from the mouse to go all the way to the spermatogenic line just to train ourselves to recognize this cell. It's beyond embryology, it's just and nothing to do with embryology, honestly. It's just reproductive biology at its best.
So I think you've given us a lot of tips on selecting the sperm or so that we can have healthier, genetically normal embryos. Now, when we look at data, and there is no doubt that we cannot survive without ICSI, male factor infertility is rising. But when we look at the data for non-male factor infertility, and you look at conventional IVF versus ICSI, it is nearly the same. I mean, it is,
True.
and it is true. So in that case, which is understandable, in that case, what is your take in doing ICSI for all the patients? Do you are for it? I mean, if it's
I don't propose this because I develop ICSI, so it doesn't sit well with me.
Okay.
I let people to choose. But one thing I want to say is naive and ridiculous when they compare ICSI in non-male factor with standard IVF. There is no reason why ICSI should do better.
Exactly.
What is interesting to me, ICSI doesn't do worse.
Okay.
So the study design is ridiculous.
No.
ICSI was designed to overcome the problem that IVF had. So the poor sperm. No, it's not supposed to be better than IVF.
100%, no doubt about it, and it is playing a big role.
What I think it is, ICSI is an evolution of IVF.
Yes.
We are moving away from IVF because no one want to deal, especially in the US, with the surprising absence of fertilization. So, and that's the reason why we do it. But ICSI requires more timing, more attention, more dedication, more skill, better machine, better environment, everything.
So, sir, now we are talking about your lab, your clinic, and the way you are training people, the experience, the amount of time they spend looking at sperms, apart from during the procedures. So it's a totally different, which may be very unique. And you've all yourself said that yours is a very unique kind of a setup, which is possibly not existent, maybe in remote 1 or 2 places across the world.
Possible.
Now, yeah. So having said that, when you have classical cases, and in India, we do have cases for IVF where there are blocked tubes, tuberculosis is still there. And where, it's a classical female factor. Shouldn't we give chance for nature to select the sperm, then going for ICSI? What's your take? And I'm not talking about your lab. I'm talking about general average.
Sure. I don't know if nature, whatever, I don't think that would be the alternative. I think what's the simplest method that work with you? Because when you do IVF, if it's a tubal factor, you can do standard in vitro insemination. If you're successful, do that. There is no problem. That's you shouldn't worry about do something more difficult. It's a medicine ethical concept, primum non nocere, that you do the simplest things that work. The problem is there is a recent paper that showed that so many people that do IVF, they can then conceive spontaneously. So I think we're pushing the envelope on any aspect. And the same thing where we're doing PGTA for younger couple. It's the same we're doing intrauterine insemination where people should just be taught how to have intercourse. I mean, that's true for any aspect of our living, of our intervention,
Yeah.
So many doctors do immediately certain they are interventionists and they do a certain procedure on a patient when you could just wait.
Yes. No, I agree with you totally on that. And it's individual decision, it's couple's decision, it's also various factors. It's not just that. But sometimes I do believe that in cases where a simple technique is available, like you said, we should go for that.
Absolutely.
So if it is unexplained infertility, yes, I would surely say go for ICSI, or maybe if you have sufficient oocytes, do both.
I was explaining to you our tendency, we do ICSI now, to be conservative, I would say 98% of the case. I think this year we're over 99. But we have 3 different directors in the laboratory. So I don't decide the case, they go to ICSI. Normally, since the stimulation sheet, the physician decides. They have 2 different boxes. They check ICSI up front or ICSI considered.
Okay.
So that means they counsel the patient accordingly.
Okay.
Then the director of the lab look at the case and said, we can do IVF or we can do ICSI. As soon as the slightest things with the sperm, they move it to ICSI. Something is not right with the egg maturity, the slightest things that they don't feel is right, they move it to ICSI. So it's somebody else's decision. It's not my decision or my team decision. So we were given more ICSI, but somebody else said they don't do ICSI. They do IVF. So it should be their interest in doing more IVF.
No, I understand, because yours is a very unique case, and somebody who's worked in the same place, the same setup for 3 decades, it's a different scenario, because the inherent knowledge which you are passing on to people working with you and the students is very different. But look at an average scenario across the world where there are so many clinics, like India has a sudden spurge in clinics. So a lot of embryologists who don't have that level of experience work for a few months. So
even to remove the cumulus cell, the experience is disappearing. But also we work, you see, Cornell is not the first place. If people at the first attempt, they go somewhere else, where it's cheaper, when it's easier, close to their home, etc., where the insurance take everything. They come to Cornell only when they start to appear problem.
Yes. So for the message for the younger generation who are doing, I do believe that, we should do something where a non-surgical intervention. So I always joke with students saying that even for the best surgeon, if there is medical treatment, they would opt for that, then go for a surgical one for any treatment. So should that message go that where possible, you can go for conventional IVF, and, and of course, male factor, which is on the rise across the world, we have no choice. So it's not that conventional IVF is dead. Because yours is not even a tertiary, you're the,
I think what's happening is
4th level.
We are learning more about what in the past was idiopathic infertility.
Yes.
It's possibly due to sperm dysfunction, even if there were normal semen parameters.
Yes.
Or apparently normal semen parameters.
Semen parameters, we are just.
So that's the reason why I don't know that really. But yeah, male factor, I give it to that. I think we're learning more about the male, and that's the reason why we found more male factor. But I agree. I would be conservative. There is no reason to do procedures that are not necessary.
Okay. So
I'm perfectly in agreement with that. I'm not here to say the ICSI should be done with everybody, because when you do more ICSI, you will have problem with ICSI, because ICSI has its own issues.
Exactly.
Again, timing particularly.
Yeah. Because
if the egg is not ready, with IVF, you get away with it.
Yes, they have a lot of time. Nature takes care of the timing. You leave them alone and nature. Here, especially when you started saying that nuclear maturity and the cytoplasmic maturity don't match, and we're injecting. And that's possibly one of the reasons fertilization failure may occur, but more so even developmental competence may be compromised. So that could be one of the reasons that we're not getting the right timing. And that's the reason we are not getting better rates in non-male factor patients. Now we have discussed so much about ICSI, and we have no doubt it's revolutionized. But if we look back in time, we would say 50% is female factor 30, 40 years ago, 40% is female factor, male factor was just 20%. Today, male factor is more than 50%, and it is not just biased, because our semen analysis techniques haven't changed, revolutionized. We are actually seeing more. I mean, semen analysis is what we did in the 80s. Nothing has changed to a great extent, but we are really seeing so much of male factor. Does it bother you? Why do you think it has happened? Should we as scientists, instead of, we are offering treatment, but also go back to see what can we do to prevent this? Because I think prevention is something which we'll need to look at. The rate at which male infertility is
Oh
rising.
yeah, prevention. Yes, of course. It's what we eat. But when is the genetic? You see, I don't think couple should be allowed to reproduce unless they know the genetic profile of each individual. That's what will happen one day.
To what level do you talk about genetic profiling?
Spontaneously.
No,
People
in
that
general,
get married, they should not reproduce because they're going to have an unhealthy child. And when I say unhealthy child, will be obese, high blood pressure, cardiomyopathy, and you name it. So we should have as a dating app should be available in expanded carrier screening. It will happen. I have no doubt about it. Because when you want to choose your partner, you don't want to choose the way they look, but the way also stand for. So genetically. So then you are going to be kind of aware of creating a progeny that will be healthier and
would you
not
look
be a
at
burden to society.
only karyotyping? What to what level
No,
of genetic
karyotype is
testing?
not enough.
So what,
It's
how, to what level?
inheritable disease. You want to screen for inheritable disease. It is there since generation and people don't even know.
So to what level should we screen?
The expanded carrier screen, now we could do 870 gene. That's what we do for the female and about 700 for the male. That's what we should be doing. All the couple before reproducing. That's how I see it. That's my humble opinion. That's what will happen in the future. As much as the government want to control, if the government want to reduce the cost of healthcare, like you say, healthcare, we look at what we do, disease management. Healthcare would be disease prevention. If we care about the lifestyle, the diet, the health of the air, the water, the environment, we'd have better people, healthier people.
So there's no doubt all that is deteriorating. Quality of air is deteriorating, quality of food is deteriorating, quality of water is deteriorating, everything is getting polluted.
In the US, people, the large majority, other than New York, everyone is obese. Over 60% are obese, and they eat wrong, they eat too much. For example, simple things. And now this Ozempic, all these medication that are so popular, because just is ridiculous. We overeat, and then we use medication to get back to where we were. So everything need to be reconsidered, remanaged, and there is a rethinking across the line.
The point is, even a person who starts using drugs or alcohol before, they always feel, I will never get addicted. But you never know when you would. So, everybody thinks lifestyle, yes, it's for the others. It's cognitive dissonance. It's somebody else. It's not me. So smoking, everything for that matter, eating wrong foods. Do you think as scientists we get people to understand that it is not just you, but the transgenerational effect? Do you think that would help people? How do we get people to change? Because it's well known now, plastics.
When you're not happy with something, that's my take. Now I'm giving a suggestion to the young embryologist, the young scientist. When you're unhappy with something, you think something is not right, instead of worrying about changing other people, you can do one thing, one simple thing that is in your power. Change yourself. So focus on what you can do to do something different, something better. See, if you can do that yourself and everyone look for themselves, changing our own little self will be a model. And if everybody does the same, we will have a better world.
It's a very philosophical statement. Be the change that you want in others. And that was what Mahatma Gandhi had said. So it's nice to hear it from you.
Oh, yeah, you see, bring the mind, think alive. You don't want to change people by ordering them, but being a leader of an example.
True. The last week we had a webinar where we were discussing a couple of papers on toxicity of plastics used in an ART lab. So there was this paper, I think, in Human Production. We talked about cumulative effects of plastics and disposables used
plastic,
in it.
yes.
And also,
it was an article today, yes.
Yes. And also altered gene expression in mice embryos with plastics. Your take on that, because you're talking of the impact of plastics on human health. What about embryo health?
I'm aware that we inject, at least in the US, about every day, about the size of a credit card in plastic.
Do you think it's something to...
That's what we ingest. I mean, think about, can you imagine any food you eat that has not been in contact with plastic?
Impossible.
Or drink?
Yes.
Even
Everything.
if you think the paper cup that you get in the office to get
Yes.
your coffee is coated with plastic, otherwise
Yes.
it wouldn't be impermeable.
Yes.
The plastic bottle, the water, now I drink tap water. In New York City is filtered, and my building filtered. I use tap water and I gas it because I like sparkling water. But I don't buy a plastic water in a plastic bottle. So think about. And that's in our sea, in our water, killing our marine environment, and it's everywhere. And now recently I found out that in the milk, they discover traces of avian flu viruses in the milk. So there you go.
Yeah, I mean, it's opening out a totally different world, and it's something where a lot of people need to come together to talk about change yourself, and hopefully we'll have a ripple
Some
effect.
Italian, they refuse to drink water that's been in contact with plastic. They like only a glass bottle, for example. So it's an idea there.
Okay. So, I mean, interestingly, in India, we didn't have plastics as much. You know, we would use earthenware. So in the summer, the earthenware, the pots would keep the water cool. So we had things which have been, because of so-called technology has messed up the world. So now, we're going to IVF and we're seeing a lot of innovations coming in, new things coming in. Maybe you would have automation. So what do you see in the future? Because automation brings about a lot of consistency to a great extent. It brings about more precision. I mean, humans. So how far do you think automation would go in the field of IVF?
Well, I think it must occur because we have to reduce cost.
Yes.
So the way I see it, the simple cases of in vitro fertilization will be done in a microfluidic chip the size of an iPhone. And so the patient will pay just the cost of the cartridge. And so it will be very easy. Like this, you'll be able to allow to use in vitro fertilization procedure to regular couple. That's how they should reproduce. You will do pre-implantation genetic testing. When the embryo is normal, you'll transfer to a normal fertile couple. That's what I think. Will be very inexpensive, $200 or $300 the most. Will be covered by insurance, no problem. That's how I see it. The difficult case will come to our laboratory where skilled embryologists will take care of things.
So how far do you see this innovation coming in?
Well, I have a patent at Cornell on that, on the ICSI chip. We're working with Cornell. We know Cornell has a main campus in Ithaca, upstate New York. And then I work with a group of engineers where we have created a system to microfluidically select spermatozoa, the most motile, the most competent spermatozoa, and we are refining a machine that removes the cumulus cell by acoustic wave, by kind of ultrasound. So now we have to work on the injection because I think in order to have an automated IVF machine, won't be by standard IVF, will be through ICSI, because you must know the exact time the two gametes join together. So that's the reason why you need ICSI. That's the reason why I say ICSI is an evolution of IVF and not a replacement. It's just IVF itself evolved into one sperm, one egg. That's what I think. With all the respect for Bob Edwards.
Yeah, it's evolution. So if that platform was not created, this wouldn't have been there. So when do you see this? 5 years, 10 years?
The next 5 to 10 years.
Okay. So then what will be the role of the embryologist? Because you'll have the highly skilled ones where the bad cases will go.
I see an embryologist. What does it mean to be an embryologist? An embryologist it would be a clinical embryologist, would be somebody trained into genetics, andrology, and embryology. But you see, we're confusing an embryologist. An embryologist is somebody that knows the development, the ontological development of an embryo, not somebody that take the pipette, an egg into the dish, and they put it in the freezer. That's not an embryologist. That's a technician. And that's may disappear, or may just watch the machine, make sure that the machine does its work properly.
So the embryologist will
Have to study more.
Have to study more and use more of the gray matter than
Higher degree.
Yes.
That's how I see an embryologist with a PhD.
Okay, thank you. I think there is, if it's okay with you, we can take questions from the audience, one or two. I've taken a lot of your time. Yeah, there's just one that you talked about fish. So how does that work, a fish before selecting the sperm? I think we missed out.
Well, the fish will be done on the sample that is not used for the injection. You have to fix the sperm, and you will assess with fish the way we do it. We're 3 to 4 labs in the world that do this, 10 chromosomes. That's all we assess. So it's not 100%. In order to have a complete karyotype, we do NGS sequencing. That's more costly, more expensive, but we can do the entire karyotype of the patient. It's very important for translocation and when you know that there is specific chromosomal abnormality.
One last question. You said you're always playing. You don't work, you play all the time.
Oh, yes.
So what else does interest you?
Oh, really? Boating. I like to be on a boat.
Okay. Interesting.
I like sport car.
That's why you equate it to the Ferrari.
And I like to modify things.
Okay.
When something is not there, you see, we have, we have our hands, but if our hands are too big, we create tools. And to create tools, you use your brain. And you can make any shape you want with your brain. So you have to be focused. You have to be passionate. Anything you do, doesn't matter. You just embrace something and you go very deep, like you said before, on making that things better.
Okay, I think, Dr. Palermo, we are at the end of the day. But for you, it's the start of the day. And we've taken more than an hour of your time. I thank you so much. It has really been very motivating and interesting to talk about various aspects, from new discoveries to the pressures of new discovery. And I think a lot of young embryologists do get a lot of message. And we are going to have it on YouTube. So I think people can listen to you again. So
it is a joy working with you and talking to you.
Thank you so much. And we hope to host you in India one day and see our beautiful country.
Yes.
It's something which would be. So,
thank you.
Thank you. And on behalf of the Academy of Clinical Embryologists, I formally thank you for taking your time. And maybe we'll have talks on something else in the future. So formal. The idea of these conversations was to have an insight on the individual. Scientific papers tell us something, but what all you said goes behind the scenes, how one thinks, how one works, what passion is, what involvement is. So I think these messages are never, it's like what they say, what they don't teach you at Harvard Business School. What they never teach in a lab comes through conversations. So thank you so much, Dr. Palermo.
My pleasure. Thank you.
Thank you.
All the best.